The subject of this talk is cardiac tumors and thrombus. Cardiac mass may be primary neoplasia, metastasis, thrombus, endocarditis vegetations, and frequently normal structures that may simulate abnormal mass. Let's see them all. To begin with, the primary benign neoplasia, and the most frequent of them is the myxoma. This tumor originates from the mural endocardium. Typically, it is pediculated and adherent to the interatrial septum, often encountered in the left atrium, but also found in the right atrium, in the ventricles, and rarely in the atrioventricular valves. When in the atrial cavity, it may cross the orifice of the AV valve, causing obstruction to flow. The aspect of this tumor in a 2D echo is very characteristic. Since it is pediculated and often with a long pedicle, it is highly mobile and goes to and from the mitral orifice at each diastole, as seen in this long X view. During diastole, it follows the blood flow through the mitral valve and goes to the left ventricle, and with the beginning of systole, it returns to the left atrium. The diagnosis is easily made in this view, where we're going to measure it. Notice how it may seem friable, easily compressed and deformed. It may look quite jelly-like. Next, we must ascertain its attachment to the atrial septum, since this is its main characteristic. When we demonstrate its attachment to the interatrial septum with a pedicle, we may be very confident it's a myxoma. Inside the atrium, when there is a long pedicle, and depending on its size, it may be seen only during systole, since it moves toward the left ventricle in diastole, as in this short X of the base. Next, we must ascertain its attachment to the interatrial septum, since this is its main characteristic. When we demonstrate its attachment to the IAS with a pedicle, we may be very confident it's a myxoma. As demonstrated in this apical four-chamber, notice here its attachment to the atrial septum. This is so typical that if we can demonstrate the tumor attached to the atrial septum by a pedicle, there is no need for a transesophageal echo to assure this diagnosis. However, if it is too big and we are not sure of its adherence to the interatrial septum, we cannot be sure it's a myxoma, and a transesophageal echo may be necessary to show this pedicle and where it is attached. Then, with a transesophageal echo, we can visualize the pedicle, which may be very small, attached to the septum. The tumor may be very multi-lobulated, with a fragile aspect. We can see why it may embolize frequently. Another example, see how its jelly-like aspect goes across the mitral valve. It practically deforms to adjust the mitral valve. See that at this short X of the mitral valve, how it appears during diastole and disappears during systole. Here is a large LA myxoma. It apparently had a pedicle attached to the left atrium, as suspected in this apical four-chamber, but a TEE is needed to ascertain its attachment to the atrial septum. Another example of a left atrial myxoma, very close to the mitral valve. The TEE in this view does not show, but it was adherent to the interatrial septum. Notice that it might as well be attached to the base of the mitral valve. When the pedicle of the tumor is too close to the mitral valve, it may be difficult to be sure it's not attached to the anterior leaflet, even by transesophageal echo. This is mainly due to the poor temporal resolution of the 2D echo. M mode and its superb temporal resolution may help then. Here we see a M mode of the mitral valve, and it is perfectly noticeable that the tumor is not attached to the leaflet. See that the valve opens and there is a moment with no appearance yet of the tumor. Then it comes from beyond the posterior leaflet and appears suddenly behind the anterior leaflet. Notice that for the remaining diastole, it seems to be attached to the anterior leaflet, and that would be our impression if we had noticed no time between the opening of the valve and the tumor appearance. The poor frame rate of 2D echo may not show this interval, and the differentiation of the attachment to the anterior leaflet might be very difficult if it were not for the M mode. Here, different transesophageal echo views of a LA myxoma. Note the pedicle attached to the interatrial septum. Notice also that the echogenicity of the mass is not homogeneous. This is common with myxoma. Like this one, there are several small areas of much less echogenicity. Look at this one. These less echogenic areas may indicate fast-growing mass when the blood vessels are left behind and create areas of necrosis, and may be more frequent in malignancies. However, it's not a good sign for malignancy, since it's also common in non-malignant tumors due to local hemorrhage, not distinguishable from necrosis. Here we see a right atrial myxoma, the second most frequent location of this kind of tumor. It has the same characteristics as noted when in the left atrium. It's mobile. During diastole, it goes through the tricuspid valve toward the right ventricle. During systole, it's sent back to the right atrium. It's pediculate, and most of all, attached to the interatrial septum, what characterizes it as a myxoma. Another right atrial myxoma in a subcostal view. The picture is during diastole, and this mass passes the tricuspid valve toward the right ventricle, but it's attached to the interatrial septum by this long pedicle. Occasionally, we're surprised as this one here, a large mass in the left lateral wall. It seems not to be pediculated. By the aspect of this mass, as we are going to see next, is very suggestive of fibroma, but surgery showed it to be a myxoma. In this example, in this transesophageal echo, it was a mobile pediculated mass attached to the IVS in the left ventricular outflow tract. It had caused already an embolic episode, and at surgery, it was a myxoma. Then the myxoma is an easy tumor to identify and to diagnose as such when in the atrial cavity, adherent to the atrial septum, but as most of the tumors, is impossible to identify as such when in a different location. Another primary benign neoplasia is the papillary fibrillastoma. It's also pediculated, small, usually less than 1 centimeter. It has a finger-like appearance and is usually found attached to a valvular structure, most commonly to the aortic valve, but may be encountered in any cardiac endocardial location. It's also mobile and very echogenic. Here an example. Transesophageal echo seeing the aortic valve in short X with a small pediculate echogenic mass attached to the aortic cusp. Usually it does not impair the function of the valve unless it becomes too big. The main problem it causes is the possibility of embolism. One can suggest being a papillary fibrillastoma if these features are found, but only a surgery can diagnose it. Notice that at M mode it seems a vegetation, as we have discussed already, with the aspect of cloud without any lines. There was no ragged paper sign though, but the differential diagnosis here is by the clinical situation and the kind of mass defined by surgery. This is another papillary fibroblastoma found in the mitral valve. Another primary benign neoplasia is the fibromas. It is a single intramyocardial mass, not pediculated, and well-defined borders. It may be oval or circular shaped. Usually is an accidental finding. Here an example. Notice how this case is very like the myxoma presented before. This case here has all the main characteristics of a fibroma. It's a single mass, big. It was an accidental finding. The patient had no symptoms, and it's coming from the wall. All this make you think it's a fibroma, but once again, only surgery and pathology may define the kind of tumor. This is another example. It was the first fibroma I had seen. It was in a 13-year-old child, a large fibroma. Notice it's a single echogenic dense mass. The wall seems to preserve its contractility. Interestingly, he was operated on and the tumor was removed, and later this patient returned for a post-operative echo, and the exam was completely normal. Not even an abnormality contracting lateral wall. Then it's a benign tumor and usually good surgical results. Another benign tumor is the Rhabdomyoma. They are easily diagnosed. They are very frequent in children with tuberous sclerosis. Because of this association, these children are sent to the echocardiographer by the pediatrician to see if there is any tumor. And if any mass is found, we can almost assure it's a rhabdomyoma. It may be pediculated or intramyocardial, single or multiple. It's very echogenic. The diagnosis of this kind of tumor is easy because of the association with tuberous sclerosis. Here an example. Both views are subcostal. Multiple masses obstructing the right ventricular outflow tract in a child with multiple sclerosis. The child was operated on because of this obstruction. Another interesting feature about this tumor is that once diagnosed, if it is not producing obstruction or any hemodynamic problem, surgery can be postponed, no matter its size or no matter its numbers, since the tumor can have complete regression and disappear totally.